So it deals with an approach, practical approach to syncope. Syncope is defined as abrupt, transient, complete loss of consciousness and postural tone with rapid spontaneous recovery in absence of features of alternative diagnosis. On the left side of the screen, you have a nice algorithm that belongs to the European Society of Cardiology. And you ask the first question, is there a loss of consciousness? If no, then you might be dealing with falls or altered level of consciousness. The second question, is it transit or rapid onset, short duration, and spontaneous recovery? If no, then you think of coma, aborted sudden cardiac death, or other situations. If yes, then you are dealing with either a traumatic condition or non-traumatic condition. If it's non-traumatic conditions, then the differential diagnosis falls between syncope, epileptic seizure, psychogenic, and rare causes like catalepsy and narcolepsy. Catalepsy is usually loss of postural tone and maybe consciousness in relation to emotional stimuli like laughing. And narcolepsy is the association of catalepsy with other conditions like hypnagogic hallucinations and sleep paralysis. We have a lot of references. Two of them are extremely important, and this include the 2017 American guidelines on the evaluation and management of syncope, as well as the more recent 2018 European Society of Cardiology guidelines for diagnosis of syncope. I have a book here which is very helpful in that regards. Contains 250 cases of syncope. The author is Roberto Garcia, and it includes everything about syncope for those who are interested in this entity and wanted to have an in-depth knowledge about the condition. Now, it's a common condition, and I will tell you how common it is shortly. It's costly in relation to the expenditure on healthcare. It's disabling. It can cause physical injury, loss of independence, and can lead to sudden cardiac death, particularly if syncope is of cardiogenic origin. The goals is to establish a specific diagnosis, rule out conditions with risk of sudden cardiac death, establish treatment plan, and reduce the risk of recurrence, and use the resources efficiently. This is on the right side of the slide. You have a broad classification of syncope. About half of the cases is due to the first two causes: neurally mediated hypotension, which includes vasovagal syncope, situational syncope, and carotid sinus hypersensitivity, and these constitute together about 35% of cases. Orthostatic hypotension is the second common cause, and both of these conditions constitute about 40 to 50% of patients with syncope. The most serious condition that needs to be excluded in every patient with syncope is a cardiac cause of syncope. If you faint because of cardiac origin, then the next step is a funeral. A faint leads to a funeral. Rarely it's due to cerebrovascular. This constitutes 1% or less. And sometimes you have to differentiate syncope from syncope mimics like seizures and psychogenic syncope. And despite everything, including history, physical examination, and very astute investigations, there remains about a quarter to a third of cases of unknown cause. If you can't reach the etiology of syncope, that's a bad sign, because it carries a mortality rate somewhere between normal and cardiogenic shock, and I will show you the curves which illustrates this phenomenon. Now, if we detail the classification, actually we have two non-cardiac causes and two cardiac causes. The non-cardiac causes are include the reflex or neurally mediated syncope. These include vasovagal syncope, which can be precipitated by emotional disturbance or orthostatic. Situational syncope, which is very similar to vasovagal, but is precipitated by cough, micturition, exercise, or some form of pain like glossopharyngeal neuralgia or trigeminal neuralgia, and carotid sinus syncope, which we will detail soon. And the second non-cardiac cause is orthostatic hypotension, which can be due to primary autonomic failure, and primary autonomic failure includes Parkinson's disease, multiple system atrophy, and pure autonomic failure. Pure autonomic failure is a rare syndrome which includes syncope plus bowel, bladder, and sexual dysfunction. And if you add to this manifestations of Parkinsonism and ataxia, then you get multiple system atrophy. Orthostatic hypotension can also be secondary to secondary autonomic failure due to diabetes, amyloidosis, or spinal cord injury, or the result of drugs, particularly vasodilator effect of alcohol and other vasodilator drugs, or volume depletion as a result of intensive diarrhea or hemorrhage. Cardiac syncope, which is a much more serious condition, can be due to bradycardia or tachycardia, or can be the outcome of cardiovascular structural diseases, including aortic stenosis, myxoma, hypertrophic cardiomyopathy, or extracardiac like pulmonary embolism, aortic dissection, or pulmonary hypertension. Now, these are two studies that are very often mentioned in the literature about the prevalence and the incidence of syncope. The prevalence was estimated in the Olmsted County in the region of the Mayo Clinic, and it tells that the prevalence of lifetime prevalence of syncope is about 30%. And the incidence here is a study of more than 7,800 patients from Framingham study, and the incidence is about 6 per 1,000 per person year. So as you see, it's a very common condition, and it's a very disabling condition. Now, these graphs compare the prognosis of normal individuals in yellow color here, with normal individuals in black color here, with vasovagal syncope. And as you see, the prognosis of patients with vasovagal syncope is exactly like normal. There is no excessive mortality when you diagnose vasovagal syncope. But in red, you have here cardiac syncope, and we can see it doubles the mortality of in patients with or having a cardiac cause for syncope. And in between, you have neurogenic syncope as well as syncope of undetermined etiology. So if you can't find a cause for syncope, that's an ominous sign, because it tilts the balance towards a more drastic situation, going towards the poor prognosis of cardiogenic syncope. Syncope is common in the elderly, and it has another peak in the teenage. So it's a bimodal condition with one peak in ages and the other peak above the age of 65 or 70. It increases with age. It can be mistaken as falls because of retrograde amnesia of the event. There is a heightened concern about injury and disability and loss of independence. And there is greater incidence of carotid sinus hypersensitivity, which is defined as pauses of arrest of 3 seconds or more on carotid sinus mesh. It might respond to pacing, particularly specific forms of pacing that we will come to soon. And then in all the age, we have also to consider orthostatic hypotension, which might be existing with supine hypertension. Under these circumstances, you have to strike a balance between dropping the blood pressure by vasodilators and elevating the blood pressure by fluid loading and other conditions that are we going to mention. Well, of course, the priority will be given to the treatment of syncope, but at the same time, patients should be nursed in the semi-supine position, and the blood pressure should be measured in that situation. Pyridostigmine, by blocking the sympathetic nervous system and enhancing vagal activity, is specific for the combination of orthostatic hypotension and systolic hypertension in the same patient. Now, having said that, we move to question number 1. A 25-year-old woman presents to you with recurrent syncope. She is getting palpitation during piano playing, and she gets often fainting attacks during the concerts. She mentions that she got 30 times episodes in her lifespan, and this was prolonged prodrome of lightheadedness after the spells, and she has no tongue biting or other physical injury. Physical examination and the ECG is normal. So having mentioned that, what is the most likely diagnosis? Supraventricular tachycardia, postural orthostatic tachycardia syndrome or POTS, vasovagal syncope, psychogenic syncope, and partial complex seizure. Partial means focal, and the complex means associated with loss of consciousness. So as you see, this is the typical description of vasovagal syncope. You get a young age, you get frequent attacks, you get prodroma, which is prolonged, and the prodroma is usually associated with palpitation, nausea, and sweating, and you don't get a fatigue or a prolonged after effect of the condition. Physical examination and the cardiac examination must be normal in these individuals. So during the evaluation of syncope, it's very important to get a good history. The history is number one clue to the diagnosis, but by itself is not diagnostic. It has to be confirmed by investigation, but it directs you in the appropriate way if you get the details of the event, particularly the precipitating event. The most important point in the history is the precipitating events. Also, the history of medication, family history, particularly related to cardiac disorders and inherited arrhythmias, postural vital signs, cardiac and neurologic examinations, and every patient with syncope should take an ECG. Under special circumstances, you need other investigations, including an echocardiogram, exercise test, Holter monitoring, or ILR, implantable loop recorder. And in cardiac patients, you need an EP study sometimes. Very rarely you need neurological tests, particularly if the patient is having focal neurologic signs on physical examination. And nowadays, most people can reach the diagnosis without resorting to tip-the-table tests. So if we look to the details of the different types of syncope, cardiac syncope is characterized by occurring in old age, male sex, few lifetime spells, short prodrome, history of cardiac disease, syncope while supine or during exercise, palpitation, family history of sudden cardiac death. So if you can encounter any of these things, either in the examination or in real life, then directs you to cardiac syncope. On the other hand, vasovagal syncope is characteristic of young age, more life spells like the previous case we just described, prolonged prodrome more than 10 seconds, no evidence of cardiac disease, occurring always in the upright position, may be associated with stress or pain. There is a prodrome of diaphoresis, warmth sensation, nausea, and pallor, and there is mild fatigue afterwards, and the presence of a specific environmental or situational trigger. On the other hand, seizures, it should be thought of in presence of organic brain disease, tonic and clonic fits. Sometimes you get myoclonic fits after vasovagal syncope, but that usually lasts a few seconds. But if you get it prolonged, then you think of seizures rather than syncope. Head turning, tongue biting. Tongue biting occurs usually at the side of the tongue, not at the tip. It can occur at the tip in vasovagal syncope, so the site of tongue biting is important in the differentiation between seizures and vasovagal syncope. And then you get an afterward effect in the form of confusion and delirium. So historical features are often very important, but they are non-specific. So alone history and physical examination is not diagnostic, needs to be supplemented by the results of the investigations. The investigations should start off obviously with simple things. After doing physical examination, looking for signs of cardiac abnormality, starting with the ECG, which should be done in every patient with syncope, looking for signs of structural heart disease, including cardiac hypertrophy, evidence of infarction, arrhythmogenic right ventricular dysplasia, or cardiomyopathy, where imaging will be playing an important part. And signs of conduction defects, including bundle branch block and AV block, and signs of inherited arrhythmias like WBW, long QT, and Brugada syndrome. Occasionally, an echo is required to declare structural heart disease, including aortic valve disease, cardiac tumors, pulmonary hypertension, and cardiomyopathy, which can be a predisposing factor for ventricular tachycardia as well as ventricular fibrillation. And here we get the value of advanced imaging, including cardiac CT and MRI, which by tissue characterization can help the diagnosis of conditions like ischemic cardiomyopathy and non-ischemic cardiomyopathy, including infiltrative disorders, inflammatory disorders, genetic disorders. An important cause of syncope is coronary artery anomalies, now easily diagnosed by CT and MRI, and we'll come to that. Valvular heart disease, myocarditis, and fibrosis due to toxins like alcohol and cocaine, and long-standing diseases like hypertension and diabetes mellitus. All of this needs imaging to verify the diagnosis and help establish the condition. Now, this is an MRI 2-chamber view and 4-chamber view. Even without having it in real time, you can see that there is no thickening in the apex in the 4-chamber view here, and also in the anterolateral and the apical part here. What we are looking for here is not movement, it's tethering, it's thickening to avoid the phenomenon of tethering. So dilatation of the ventricle, segmental wall motion abnormality, even in a static picture, will be helpful to declare an underlying cardiac condition. Under these circumstances, ventricular tachycardia will be the foremost differential diagnosis in this condition. One important thing here is that this MRI, there is no contrast needed. It's the rapid flow of the blood which creates the contrast by itself, so it saves the patient the risk of having a contrast. And the axial view is extremely important in diagnosing conditions related to syncope, because as you see in the upper panel here, these are axial cuts, transverse cuts across the torso or the human body, starting from the base of the heart and going down to the diaphragm. And as you see here, behind the sternum, you can see the right ventricular and the right ventricular outflow tract and the right ventricular body itself. And also posteriorly, you see the left atrium and the pulmonary veins. So here the sternum, unlike with echo, does not obscure the depiction of right ventricular structures. And this is even more easily seen, right ventricular morphology, with the sagittal view. With the sagittal view, the sternum again does not produce any hindering effect on imaging the right ventricular outflow tract, the pulmonary artery, and as well you can see the outflow tract of the right ventricle for the diagnosis of condition like arrhythmogenic right ventricular dysplasia. Now, this is arrhythmogenic right ventricular dysplasia with the Hopkins criteria, major criteria and minor criteria. Remember, we concentrate essentially on dilatation and areas of dyskinesis in the right ventricle. We are not concerned with fat infiltration, because although fat infiltration is a major criterion and to a less extent minor criterion, but it is fat infiltration by biopsy, not by imaging. So by imaging, we concentrate on right ventricular dilatation, right ventricular dyskinesia, decreased fractional area change, and these are the figures which are considered as major criteria, and they are the same as minor criteria but less intense. So the diagnosis depends on the presence of two major criteria or one major criteria and two minor criteria that leads to a definitive diagnosis, borderline diagnosis, one major and one minor, or three minor, and possible diagnosis, one major and two minor. Anomalous coronary artery imaging. In the past, we used to make a lot of tricks during cardiac catheterization by putting a catheter in the aorta and another in the pulmonary artery and angulating the tube in different positions, particularly the left oblique cranial angulation, but it was a cumbersome process. Now we can easily diagnose these conditions by MRI and CT. CT is more important in depicting the degree of stenosis, but the origin of the vessel is more clarified by MRI. And if you look into this axial position here, is the left main coronary artery passing behind the pulmonary artery and the aorta, and bifurcating into the LAD, moving towards the apex, and the circumflex moving posterior. And as I mentioned before, this kind of imaging supersedes cardiac catheterization in depicting not only the arteries, but as well the veins. So this is the great cardiac vein going into the coronary sinus. If you make some angulation with the axial view, you can see the origin of the right coronary artery and as it moves around the right part of the AV groove and the posterior part of the artery. What we are looking for is to find any vessel between the pulmonary artery and the aorta. So long as you are posteriorly or totally anteriorly, you are safe. Otherwise, you have to interfere. So imaging can be helpful in detecting various forms of cardiomyopathy, which predispose to ventricular tachycardia, as well as conditions like anomalous coronary arteries, which can be a common cause in the relatively young people for syncope. Question number 2, 75-year-old man with hypertension, diabetes mellitus, having a prior myocardial infarction, left ventricular ejection fraction of 40%, presents with sudden loss of consciousness. He has no angina or congestive heart failure. Medications include metoprolol, glyburide, metformin, aspirin, and lisinopril. Physical examination shows a heart rate of 52, blood pressure 150/70. There is a right carotid bruit. ECG shows sinus rhythm, prolonged PR interval, and right bundle branch block with normal axis. The question is, what's the best next appropriate step in the care of this patient? Carotid Doppler study, diagnostic electrocardiographic study, electrophysiologic studies, cranial MRI, insertable loop recorder, or tilt table test. Now, as you see, this patient is in contrast with the first patient, which was a vasovagal syncope. This is a highly suspicious cardiac condition, old age, male sex. Patient is having previous myocardial infarction, low ejection fraction, but not very low to justify ICD. If he is justifiable for ICD, then you don't need to make electrophysiologic studies. But this falls between the range of 35 to 45. So this is the indication for electrophysiological studies. In addition, this patient is having conduction defects in the form of prolonged PR and a right bundle branch block. Carotid problems cannot cause syncope except extremely rare. So the presence of a carotid bruit shouldn't distract you from more serious diagnosis. So the answer, the carotid Doppler study, this is the wrong answer. Cardiac electrophysiology study, this is the ideal candidate for cardiac electrophysiological studies. You don't resort to imaging of the brain except when you have clinical evidence of focal neurologic signs. Implantable loop recorder after excluding the patient, excluding a serious cardiac condition. You can implant a loop recorder and send the patient home, and then he dies from ventricular tachycardia. You should verify the absence of this by electrophysiological study before submitting the patient to prolonged monitoring. And the tilt table test is indicated essentially when you have a suspicion of vasovagal syncope, but you have no confirmation of that. So this is obviously not the case in this condition. Now, these are the various monitors that are available in the market. It depends, the choice depends on how frequent syncope occurs. If it occurs every 1 or 2 days, 3 days, then a Holter monitor will be sufficient. If it occurs during 2 weeks, then you can put a patch monitor, an event monitor, or you can put a telemetry, cardiac outpatient telemetry. All of these can be very helpful for syncope, which occurs every 1 or 2 weeks. But actually, most of the cases, they occur less frequently. So this is an indication for ILR, or implantable loop recorder. It's a very small device that can be implanted prepectorally. Now, it's so small that it can be injected by a syringe. It has no leads. There is very low risk in implanting it. It can last for 3 or 4 years. It's wireless. It can be activated spontaneously with the occurrence of arrhythmia when it detects 2 minutes of recording before, during, and after the arrhythmia that will be displayed. And there is a very effective atrial fibrillation detecting algorithm. If you look into the left side of the slide, here you will find that this patient was having sinus rhythm, and suddenly he developed wide complex ventricular tachycardia, which was responsible for the syncopal effect. This is another patient which had electrophysiological study which was negative, but during ILR monitoring, he developed paroxysmal heart block, which was not detected during electrophysiological study. Now, there is a small study which is frequently quoted in the literature called the DRAST study. which supports the use of ILR very frequently in these patients. And unfortunately, we don't have a good access for ILR locally here in Egypt. It's available, but not readily available. So this is a small number of patients of 60 patients that were randomized into two arms. One arm was a conventional monitoring. These patients had a 2 to 4 week event monitoring, a table test, and an EP study, and the other had an ILR. And it turned out that the diagnosis was obtained in 47% of patients in the ILR group versus just 20% in the patients who had the other investigations, which is called in this study as conventional investigation. So this shows the importance of having the ILR. Now, the indications for electrophysiologic study should be prudent. In unselected patients, the yield of electrophysiologic study is very low. So particularly if you have a normal echo and a normal ECG, you don't expect much from electrophysiological study. But the yield is higher in patients with syncope associated with palpitation on normal electrocardiogram, Holter monitor, or event monitoring. Most of these cases, which have a good yield by electrophysiologic study, they have structural heart disease, particularly previous myocardial infarction, or arrhythmogenic right ventricular dysplasia, or variety of cardiomyopathy. And everybody knows that we don't study usually hypertrophic cardiomyopathy by EPS because the yield is at best controversial. Neurologic testing is overused. It has the lowest yield and is a class 3 indication unless you have an evidence of focal neurologic defect or you have a history of head injury. So MRI, CT, carotid artery imaging, or routine recording of the EEG should not be recommended except when there is something in the history and or the physical that points to a neurologic problem. Otherwise, the yield would be. Ketaber test is very, very infrequently used nowadays because most of the diagnosis of vasovagal syncope can be established by other means, particularly the history of the patient. It was introduced in 1980. The patient lies on the table and his foot is supported. He is strapped to the table so as not to fall. And he is connected to an electrocardiographic monitoring and some form of a monitoring device for the blood pressure. And the protocol starts with carotid sinus massage. If the carotid sinus massage didn't yield anything, then you tilt the patient for 20 to 45 minutes upright, 60 to 70 degrees from horizontal. Now, if there is no change, what we are looking for is a reproduction of symptoms, the reproduction of the syncope, and find out whatever is associated with this syncopal episode. If there is no change, then we challenge the patient with isoproterenol or nitroglycerin for additional 10 to 20 minutes. There is variable sensitivity depending on the type of the study from 60 to 90, but the outcome is to reproduce the symptoms. And the associated findings include these changes. The vasodepressor effect, which is significant fall of the blood pressure with minimal change in the heart rate. Cardioinhibitory effect, which is essentially lowering of the heart rate without a fall, that leads to a fall of the blood pressure, or more commonly a combination of both. Or you might get an orthostatic hypotension, which is defined as drop in systolic blood pressure of 20 millimeters of mercury or 10 millimeters of mercury diastolic blood pressure within 3 minutes. Sometimes you get less drop of the blood pressure, but the reproduction of symptoms, and this is called orthostatic intolerance. Or you get POTS, which is postural orthostatic tachycardia syndrome, which is defined as increasing the heart rate by more than 30 beats per minute without hypotension. Or you might not get anything except syncope. Under these circumstances, the condition is known as psychogenic or pseudo-syncope, in which syncope occurs without a change in the heart rate or the blood pressure. So this slide shows the theoretical basis of the vasovagal syncope. The upright position will result in decreased venous return, which leads to a drop in the blood pressure. At the same time, it results in underfilling of the ventricle. The drop in the blood pressure increases the surge of catecholamines, which forces the contraction of the ventricle against an empty cavity because it's underfilled. And this sends afferent vagal fibers to the brainstem, where vagal efference results in drop in the heart rate, and sympathetic withdrawal results in vasodilatation. And both of these conditions will result in drop in blood pressure, and as a result of that, global cerebral ischemia and loss of consciousness. There might be a contribution from higher centers of the brain, which explains why shedding of blood or the warm sensation will result in syncope. It might also be related to neurohormonal activations as well as genetic factors as well. Now, the indications for the tilt table test, according to the latest guidelines, is that it's indicated when there is a suspicion of vasovagal syncope, but it's not confirmed. It's also indicated if you are suspecting a delayed orthostatic hypotension that might occur not after 3 minutes of standing, but after 5 or more minutes. It's also helpful in distinguishing convulsive syncope from real epilepsy. And it's also helpful to establish the diagnosis of pseudosyncope, in which syncope is reproduced, but there is no vital sign changes, no hypotension, and no bradycardia. It's not recommended to monitor the effect of treatment because it has a poor reproducibility, so we cannot institute the treatment and then repeat the test because it's fallacious under these circumstances. One important caveat is that a positive tilt table test should not dissuade you from a serious diagnosis like a cardiac syncope. So you use it only after excluding a cardiac condition, and in conditions in which you have one of these conditions that are being suspected but not confirmed. But anyhow, most of the time we don't need it. Question number 3. A young healthy woman presents for evaluation for several lifetime episodes of vasovagal syncope. She recently fainted during a high-stress job interview. Last prior episode occurred 6 to 7 years ago. A tilt table test showed a mixed response with a maximum 5-second pause during the syncope. Which of the following is the most appropriate initial treatment? Sertraline, Bloodrocortisone, metoprolol, permanent pacemaker, or increased salt intake? The correct answer is the last one, because most of the evidence is in favor of this. There is small evidence in favor of the SSRI, and there is also small evidence in favor of Bloodrocortisone. There is no evidence to support the use of beta blocker, and I will indicate you the different studies which tells you about the indication of permanent pacing in these conditions. So the treatment of vasovagal syncope is challenging. The most important thing is to increase the fluid and salt intake. You have to understand that giving a bolus of fluid, something like 500 cc's fluid, even plain water, has a vasospastic effect. It distends the splanchnic area, and as a result of that, the body gets misinterpreted as a vasodilatation and produces surges of catecholamines, which produces vasospasm. This is obviously different from drinking 500 milliliters of water in different volumes. So if you take it as one shot, you get vasospasm because of liberation of catecholamines. So increase the fluid intake and salt loading. Compressive stopping, particularly if it's waist high rather than thigh high, and also thigh high is better than knee high. So we usually opt for this, but there's a great non-compliance for using stopping that's high and going up to the waist. Counter pressure maneuvers like squeezing the hand grips, or crossing the legs, or assuming the squatting position, or better lying flat and elevating the leg if that's at all possible. The available medications, midodrine, there is the strongest evidence for midodrine in these conditions. The selective serotonin receptor antagonists, there is a limited experience. For Bloodrocortisone, a mineralocorticoid, limited experience, and no evidence at all for patients with beta blockers, and we will talk about the role of the pacemaker. So this is a study done several years, 6 years ago, about midodrine, and you'll see from the frequency of syncopal episodes decreased markedly with midodrine, about 60% compared with a placebo, and this was repeated in other 5 trials. So this supports the use of midodrine. Midodrine is a prodrug which can be metabolized in the liver into an alpha agonist and produces vasoconstriction, and the strongest evidence among the different drugs available for the treatment of vasovagal syncope, as well as posture or orthostatic hypotension, is for midodrine. Now, this is the SSRI for vasovagal syncope. There is a divided opinion about it. This is one study which was done several years ago. Small number of cases, fluoxetine was given against the placebo, but the difference was statistically not significant. But in another Italian study, also with a small number of patients, but using the paroxetine, the difference was statistically significant. So as you see here, opinion is divided between accepting or refuting the use of SSRI in patients with vasovagal syncope. Bloodrocortisone was tested in the post-2 trials. Small number of patients again with vasovagal syncope, randomized between bloodrocortisone or placebo. The difference was statistically non-significant, but there was, in secondary analysis, there was a hint that if you increase the dose from 0.1 milligram to 0.2 milligram, then you might get a statistical significant difference in favor of fluorocortisone. Now, several studies for beta blockers, but in the post trial, which is the largest trial, didn't show any evidence. There is a trend, if you take only patients above the age of 40, there is a trend towards benefit of beta blockers. There is another study on atenolol, and there's other small studies with divided opinions, but in the large majority of cases, beta blocker has no role at all in the treatment of vasovagal syncope. Previously, it was assumed to have a role by diminishing the contractility of the left ventricle over an empty cavity, but that's no longer held as correct concept. So the guidelines of 2017 of the American Heart American College indicates that for vasovagal syncope, you educate the patient, you teach the patient counter pressure maneuvers, you increase the salt and fluid intake. If still the vasovagal syncope occurs, then you take midodrine is a class 1A indication, and all the others are class 1B, this is class 2A, and all the others are class 2B indications, including bloodrocortisone, beta blockers, orthostatic training, serotonin inhibitors, and even dual chamber pacemaker. And I will finalize by discussing the role of the pacemaker. There is a variety of pacemakers that are being used for vasovagal syncope, including the rate drop algorithm, in which you can pace rapidly and then the rate drops after that very rapidly. This increases the cardiac output and aborts the syncopal episode, or what's called the closed loop simulator, in which the pacemaker tip measures the DPTT. If it's increased because of foot contraction of the left ventricle, then it paces rapidly to obviate the occurrence of the vagal effect as a result of foot contraction of the left ventricle. So the initial impression was with the VPS1, and which a small number of patients with a dual chamber pacemaker was compared with a placebo. There was marked difference in favor of the pacemaker, but it was thought that the pacemaker effect might be due to a placebo effect. So the larger number of patients were chosen for the VPS2, in which every patient got a pacemaker, but half of them the pacemaker was on, half of them the pacemaker was off, and there was no difference. And this confusion was partly brought back again by the publication of the issue 3. This is a slightly complicated study. It's a larger number of patients. All of them are equal or above 40 years of age. All of them having 3 or more episodes of vasovagal syncope over the last 2 years. And they had an ILR. And after having the ILR, patients that had 3-second asystole with syncope or 6 seconds of systole without syncope, all of them had a pacemaker. Half of them had the pacemaker on, and half of them have the pacemaker off. So if you have all these criteria verified, then the patients were randomized into on and off, and the on pacemaker group had a marginally statistically significant difference. So based on the issue 3, the recommendation is 2B for the dual chamber pacemaker, which is a reasonable indication in selected population above the age of 40 years of age, and with the recurrent vasovagal syncope and the prolonged pauses, spontaneous pauses. And obviously also we need the same time of pacing for patients with carotid sinus syndrome, which exhibit essentially the cardio-inhibitory response or a mixed response. So to summarize the approach to syncope, it remains a diagnostic and therapeutic challenge. Diagnosis is in a timely and cost-effective manner is required, and the history is very important, but not conclusive, should be supported by other diagnostic means. To have an ECG is critical in all patients with syncope, essentially to exclude the cardiac cause. In fact, to have a low threshold for the cardiac cause, and if you think about it, then you go through the pathway of cardiac investigations, including echocardiography and advanced imaging. The primary goal in treating and managing patients with syncope is to exclude or include cardiac cause, because this is carrying the highest mortality rate. Forget about the neurologic causes, because these are rare, and neurologic investigation should not be used except if the patient is having, by physical examination or investigation, signs of cerebral or spinal disease. Tilt table test is rarely used, should be used prudently or judiciously, and don't allow a positive result in the tilt table to dissuade you and divert your attention from a more serious diagnosis. Same applies to carotid bruit. Always, if you get carotid bruit in the examination, it's a distractor, because carotid stenosis by itself does not produce global ischemia, and definitely does not produce ischemia of the ascending reticular activation system, because that's brainstem tracts. Vasovagal syncope remains a diagnostic and therapeutic challenges, and pacing should generally be used as a last resort. So we stop at this stage and we get questions, because I know this subject is a pressing subject, and I expect a lot of questions.
شكرا.
العفو يا باشا. قول لي بقى الأسئلة.
لسه ما جاتليش حاجة.
جالكش حاجة؟ خلاص.
مفيش أي أسئلة دلوقتي.
أنا متوقع أسئلة كتيرة. السينكوب ده بنشوفها كل يوم.
في سؤال هنا عن regarding tilt-induced cardio-inhibitory syndrome.
الإيه؟
tilt-induced cardio-inhibitory syndrome. syncope.
tilt table test يعني.
is it indicated for
cardio inhibitor يعني عامل براديكال.
cardio inhibitor syncope يعني ركب لها بيس ميكر. إذا ركب لها بيس ميكر إمتى؟
احنا بنركب اولا العيانين دول هم بالتلت تيبل تيست is not enough. He should have a Holter monitor or any form of monitoring device, and then two indications for pacemaker. If he is having the syncope with asystole for 3 or more seconds, or if he doesn't have syncope but he has a pause of 6 or more seconds. So this is the guidelines. In both conditions, it's just 2B indication. So it's indicated for patients, elderly individuals above the age of 40. There is no evidence that in the young it helps. Number 2, it is indicated when there is syncope plus 3 or more pause of asystole, or 6 or more second pause of asystole in the absence of associated syncope. So this is the indication of the pacemaker.
في سؤال تاني بيقول rapid administration of fluids, IV fluids. هل ده bad management for acute cases of vasovagal syncope؟
لا، الرابid oral administration ان هو يشرب طالما ان هو syncope usually does not last except a few seconds. It's transient. هنا بنتكلم على حاجه اقل من 1 minute بالتاكيد. فالعيانين دول لما بيفوقوا ممكن تشربهم نص لتر ميه عاديه. الاورال fluid intake، الفلويد اللي المقصود هنا بيه ميه is sufficient to produce a high level of norepinephrine which produces vasoconstriction that elevates the blood pressure. What is the mechanism? The mechanism in هو sudden distension of the splanchnic area, splanchnic circulation is misinterpreted by the brain as vasodilatation. So it pulls catecholamines from the sympathetic nerve endings and the adrenal, and this produces peripheral vasoconstriction to elevate the blood pressure. ده غير ان هو يشرب 5 كوبايات ميه، كل كوبايه فيها 100 سم، دي مختلفه عن دي مش هترفع البلاد بريشر. فهو مجرد الميه دي هي اورال انتيك. طبعا العيانين دول ما بيبقوش كوماتوز ولا حاجه ومش محتاجين ان هم ياخدوا انترافينوس فلويدز، لكن طبعا اذا كان لونج تيرم تريتمنت هنا بيجي بقى ليبرال فلويد انتيك، ليبرال سولت انتيك، وبنقصد بكلمه سولت هنا هو 5 إلى 10 جرام بير داي، مش 20 مش 30.
طيب هو في سؤال تاني عن الكومبريشن ستوكينجز اللي بتستخدم في الفازو فيجاس سينكوب، هي دي بتاعت الفاريكوز فين؟
الكومبريشن ستوكينجز فيري هيلبفول، لكن الكومبلاينس بتاعها ضعيف جدا، لان اللي احنا عاوزين نركبه عباره عن كومبريشن ستوكينجز وصل لغايه الويست عشان يكمبريس السبلانكنيك اريا از ويل. اذا ما قدرناش يبقى مش اقل انه واصل لغايه الثاير. عاده الكومبريشن ستوكينجز دي بتبقى جراديويتد كومبريشن ستوكينجز بتبتدي بين 20 ل 30 ملم اوف ميركل داون and then goes up as you move up، تخف شويه شويه عشان to help moving the blood. So if the patient can tolerate it, this is a very helpful thing to obviate the occurrence of syncope، واحنا بننصح بيها العيانين، بس لازم يبقى prescription يعني ايه؟ تقول له how high وايه البريشر اللي انت عاوز تابلاي. ما تقدرش تكتب compression stocking بس، لان compression stocking ممكن تديله واحد بتاع الدوالي مش هيعمل حاجه اللي هو واقف عند الني، لكن اللي بنتكلم عنه at least thigh high او abdominal high. وusually the pressure which we select is 20 to 30 millimeter of mercury at the lower end at the gaiter area يعني الحته اللي حوالين الميديال واللاترال malleolus, and then it gradually decreases as we move up towards the end of the hose.
اللي عنده فازو فيجاس سينكوب كونتر انديكيت ان هو يسوق او يعوم؟
اوكي، طبعا الريكومنديشنز بتاع السواقه والعوم ده هو included في الجايد لاينز. في ناس not fit to drive at all. العيان اللي عنده فازو فيجر سينكوبي اكتر من 6 مرات في السنه is prohibited to drive. اللي عنده فازو فيجر سينكوبي من 1 إلى 6 مرات في السنه ده is allowed 1 month of banning، ما يسوقش لمده شهر لغايه ما الموضوع ده يتعالج الفازو فيجر سينكوبي. اذا كان العيان عنده حاجات ثانيه غير الفازو فيجر سينكوبي زي الاريثميا treated with ICD ablation or drug, then he has 3 months banning. Untreated arrhythmia is complete banning, not fit for drive. So not fit for drive, untreated arrhythmia, vasovagal syncope 6 or more times per year. 1 month of banning, orthostatic hypotension, vasovagal syncope 1 to 6 times per year, or situational syncope اللي هو بيكح مثلا او ان هو بيضحك بيجيله كاتاليبسي، ده 1 month of banning لان دي treatable condition. 3 months banning arrhythmia treated by different methods, ICD, drugs, and ablation. So these are the recommended guidelines for driving. لكن طبعا زي ما انت عارف ان كل الجايد لاينز بتقول look for the location اللي انت واقف فيه او اللي انت موجود فيه سواء بره او جوه. هل فيه نص معين في قانون المرور يحدد الحاجات دي؟ لان sometimes بيبقى في slight deviation، ما هياش 1 year ولا هي 3 months، في slight deviation من كده. So you should comply with the local regulation whenever it's available. If it's not available, here the recommendation.
إذا واحد بيشتكي من dizziness, sweating او نوزيا لما يجي يقف وهو قاعد يعني، بس مفيش postural hypotension. ده diagnosis ازاي
اول حاجه العيان لما يقول كلمه ديزنس يستوضح منه يعني ايه ديزنس، لان ديزنس دي ممكن يعني بيها فينتنج، وممكن يعني بيها فيرتايجو، وممكن يعني بيها سنس اوف امبالانس. فاول حاجه يستوضح يعني ايه انه دايخ. كلمه دايخ دي اللي احنا بنسميها ديزنس اوبن اذا كان في سنس اوف روتيشن او هالوسينيشن اوف موفمنت. هالوسينيشن اوف موفمنت ده مش ضروري يكون روتيشن. الروتيشن ده عباره مثلا السرير اللي هو قاعد عليه بيطلع ناحيه السقف، او الحيطه بتقرب منه، او الارض بتطلع لفوق. كل دي هالوسينيشن اوف موفمنت، دي فيرتايجو. الفيرتايجو اكستريملي رير انها تبقى كاردياك انرجي. كل حاجه طبعا ممكنه، لكن اكستريملي رير. نيجي للنقطه الثانيه انه هو بيشعر بفينتنج. الفينتنج دي بقى اسمها بري سينكوبي. كلمه بري سينكوبي بتستخدم بطريقتين، يا اما المانيفستيشنز اللي قبل السينكوبي، يا اما المانيفستيشنز انها سينكوبي بس ما وقعش في الارض لان ما فيهاش لوس اوف بوشر بتوع. يبقى في الحاله دي هنجو انتو ذا باث واي اوف سينكوبي اللي احنا اتكلمنا عنها في السلايد رقم 3 او 4. ان اساسا نكسكلود كاردياك كوز، وبعد كده ندور في الحاجات اللي هي فازو فيجال او بوستشر. لو هو البلاد بريشر بتاعه موطيش اللي هو الجزء الثاني من السؤال، ففي حاجتين هنا مهمين. نمره واحد، البلاد بريشر should be repeatedly measured at least for 3 minutes. sometimes يبقى في 3 minutes ده دايخ لكن البلاد بريشر ما وطاش، يبقى نكمل لغايه 5 minutes. sometimes بنخلي بعد ال 5 minutes ده برضه البلاد بريشر ما وطاش، ده بنسميه orthostatic intolerance. التريتمنت بتاعته بالظبط زي orthostatic hypotension including increased salt and water intake, compression stockings, increasing blood volume, الفلودروكورتيزون والميدودرين. دوكسيدوبا is a precursor of noradrenaline, is also used in orthostatic intolerance and orthostatic hypotension. So this is not ده نيروكارديوجينيك بس ما هوش فازوفيجال، ده نوع من الفازوفيجال. زي ما قلنا ان النيروكارديوجينيك يشمل الفازوفيجال والسيتويشنال والكاروتيد ساينس هايبر سنسيتيفيتي. فهو ده العيان اللي بيقول انا لما بقف بدوخ، هيتقاس له البلاد بريشر عده دقائق بالطريقه اللي احنا قلنا عليها، وبعدين اذا ما وطيش البلاد بريشر بنسميه انتولرانس، وبنعالجه زي الفازوفيجال زي بالاضافه الى الدوكسيدوبا ان هو almost specific للسيتويشنز.
في حضرتك برضك adenosine test in selecting patient candidates for pacing in case of syncope.
الادرينالين تيست والادينوزين تيست. انا عارف الادينوزين، انا عارف. في حاجه اسمها الادرينالين تيست والادينوزين تيست والحاجات زي كده، دي كلها كانت بتتعاطى كتشالنج على التيلت تيبل تيست. they are no longer used. اللي بيستخدم اساسا هو النيتروجليسرين. sometimes بنستخدم ايزوبروتورينول، لكن بما انه كان produce tachycardia so and abolishes the occurrence of bradycardia. انت عاوز تشوف bradycardia مش عاوز تشوف tachycardia، فما بنبقاش نستخدمه. فبقيه الحاجات دي ما بنستخدمهاش. افتر اول ادينوزين احنا بنستخدمه اساسا to induce atrial fibrillation, so we don't want to confuse ourselves من العيانين. يعني مثلا العيانين اللي عملوا لهم ablation by excluding the pulmonary veins, we challenge them by adenosine shortens the atrial refractory period predisposed to the occurrence of atrial fibrillation. So it can produce heart block from activation of the A1 receptor, and it can produce atrial fibrillation because of shortening of the atrial refractory period. Both situations are not welcome during the table test, so we don't use adenosine and we don't use adrenaline as provocative test. كان في مقالة قريبة في السيركوليشن على ان التلت تيبل تيست is completely banned وما عادش ليها أهمية وممكن ينتج منها مشاكل وكونترا انديكيشن في الاوبستراكتيف كاردياك كونديشن. الاوبستراكتيف كاردياك كونديشن بتشمل severe mitral stenosis, severe aortic stenosis, obstructive coronary artery disease and tumors. لكن هي ما زالت في الجايد لاينز بتاع 2017 و2018 عشان كده انا اتكلمت عنها. لكن في اغلب الناس بتبعد عن التلت تيبل تيست because number one of no therapeutic value, number two is very non-specific, number three زي ما قلت لك should not divert your attention from serious condition. حاجتين، لا الكاروتيد ستينوزس ولا التلك تيبل ريزلت خليك مفتح عينيك قوي للكاردياك كوزس اوف سينكوبي، لان ممكن يبقى التلك تيبل تيست بوزيتيف، شخصه فازوفيجال، تقول له you have benign prognosis and he dies because the underlying etiology was cardiac.
مفيش أسئلة تانية يا دكتور محمد.
ماشي يا باشا، هنبتدي الكونجنتال هارت ديزيز المره الجايه، دي محاضره صغيره كده اهو نختم بيها الاريزميا، واي هوب انها كانت يوسف.
شكرا جدا دكتور محمد، شكرا جدا. صباح الخير جميعا.
يا اهلا وسهلا.